Bismillah ar-Rahman ar-Rahim. I think it's time to start. We are late 5 minutes, and today is the second day and the third session today, and it's about commerce and health services. We have three distinguished speakers this afternoon. They will talk about this issue. In addition to that, the e-commerce will be handled and addressed by Dr. Al-Salama. The three speakers are Dr. Firas Ra'ad and Dr. Jack Langenbrunner and Dr. Abdullah Salama. Our third speaker, distinguished speaker, is Dr. Jack Langenbrunner, and he was introduced. He told me that he was introduced this morning, really. But I need also to just make the introduction. Dr. Brunner is a senior health economist with the World Bank, holding master's and doctorate degrees in economics and public health from the University of Michigan, United States. He is currently working in the World Bank's Eastern European region. In 2004 and 2005, he has been leading a bank team working in Saudi Arabia, in the Kingdom of Saudi Arabia, on health insurance. Dr. Langenbrunner has also authored or co-authored several prominent publications, and he will address the issue of resource allocation and purchasing issues in global context. Dr. Langenbrunner.
Thank you, Mr. Chairman. Nice to be back here again. In the past few months, two books have come out, one by the World Bank and one by the European Observatory on healthcare, related to purchasing, strategic purchasing for healthcare services. The one by the World Bank is entitled Spending Wisely. The second by the European Observatory is called Strategic Purchasing. There are several authors from those two books here with us at this conference. Dr. Zweifel, Dr. Wiley, Dennis Strevler has put out a manual that is a part of those two, a part of one of those books, Spending Wisely. So what I'm going to try to do in this presentation is to bring together some of the ideas and principles in one of those books, Spending Wisely, that was published by the World Bank. And by the way, if you're interested in either book, certainly come and see me afterwards, and I can try and help you identify the link for ordering either or both of those books. So resource allocation and purchasing, what we will do is we will first define it, and then we'll talk about some of the policy tools that are commonly available to purchasers today. And we break those down into what we like to call the for whom, the what, the from whom, and the how. And then we will finish up with the role of quality assurance, quality improvement, monitoring and evaluation in strategic purchasing. So defining our boundaries, first of all, purchasing is not procurement. And purchasing doesn't have to be associated with health insurance. Purchasing is what goes on in terms of flow of funds, in terms of management of funds between the collection and pooling and when it actually reaches the provider. It's the set of rules, the set of regulations, the set of incentives that are developed to encourage the provider to behave in an optimal manner. Now, purchasing can take on many forms, or it can be found in many organizational forms. On the public side, you can find it in the Ministry of Health. You can find it at the regional level. You can commonly find it in social insurance organizations. And you can find it in public enterprises. And certainly in the private sector, similarly, you can find it with the insurance organizations, with employers. Employers often have their own strategic purchasing, their own contracts to providers. In the U.S. and in some European countries, you see it through managed care organizations, and even individuals through their medical savings accounts can be strategic purchasers. This is the diagram that was shown a couple of times yesterday, and again I just want to refresh your memory, and you can see here the wrap arrangements, the purchasing arrangements, and where they fit into the overall schema in terms of revenue collection, pooling, and service provision. So what's been happening in purchasing over the last couple of decades is really a big part of what's in these books. In the 1980s, in some of the OECD countries, you started seeing purchasers, whether they be ministries of health or regions or social insurance programs, you started seeing them behaving differently. They started moving from passive allocation of funds using norms to something that was more performance-based, activity-based, performance-based, outcome-based. You started seeing them be a little bit more selective in who they were actually paying for services. Instead of contracting with everyone who was available, they started thinking about who was doing the best job and started to more proactively select and negotiate and contract with those providers. And while there was probably some passive quality and monitoring system, they started to implement a much more aggressive quality assurance effort, and then later a quality improvement program. I think that it first started and tended to be associated with more of the social insurance models in Europe and more of the Bismarck type models in Western Europe. But in fact, if you look across the board, you may find them equally in many different models at this point. So we've gone through the definitions. Let's talk about the policy choices, the policy tools that are commonly available to strategic purchasers. And again, we'll talk in terms of the for whom, the what, the from whom, and the how. And when we say for whom to buy, we usually talk in terms of coverage decisions. And when we talk about what to buy, we're usually talking about the benefits package. From whom, we're talking about the price and the quantity and the actual contracting for services. And the how, we're talking about the incentives developed. And specifically those incentives being developed to meet certain policy objectives. So let's talk a little bit about the for whom, the issues of coverage. I think that most countries of the world, maybe the US and South Africa being exceptions, have universal coverage. But at the same time, universal coverage, especially in insurance systems, isn't always enough. For one thing, I know in many countries where I work, workers may be in an informal economy, or they may be self-employed, or they may be farmers, and they don't pay premiums. And they are outside, de facto, they are outside of the insurance system. In Russia, there are up to 20 million people now who are uninsured, even though they have a universal health insurance system. So this is a problem. There are gaps in many health insurance systems. You find this both in Eastern Europe, and you find this in some parts of Latin America. And you also find that the coverage may be uneven, that there may be either groups that require more assistance, that may have more profound health needs, or they're not receiving services for whatever reason. The bank did an interesting review a couple of years ago, Dave Watkin, where he looked at the benefit incidence. George Schieber yesterday talked about the net incidence, how much you pay in versus how much you receive. And he looked at the benefit incidence of the lowest income groups versus the highest income groups, and he did this for countries with government systems and universal coverage. And he found that in every region that he looked at, and here we have Africa, Asia, and East Europe, that it was the rich who were benefiting from the public system relative to the poorer groups. And so I think that it's not enough to just say there's a government system, and you have universal coverage. In fact, you need to look at who actually is receiving the benefits under those services, under those systems. I think in Saudi Arabia, one of the interesting things that I have found in my work here is that the allocation per region, when you look at it from a population standpoint, from a per capita standpoint, the allocation is very different. If you look at the northern region versus the eastern region, you see that from a per capita standpoint, in terms of the allocations, it's something like a 4-to-1 difference. It's a very big difference in terms of the amount of money going for healthcare services. So again, you have a universal system, everyone is covered, but there are obviously different amounts of money going to different regions of the kingdom. So these are things that you have to think about in terms of coverage, and as I suggest already, there are kind of two classic solutions for improving your targeting. One is to change your resource allocation, your policies, and many countries have done that. They've gone from some input-based formula to more of a per capita formula with some adjustments for patient need and demand. And then they've also done some special contracting, often beyond the public system. In terms of geographic resource allocation, I think that you see it at the regional level, but then you could also see it at a more micro level. In some countries in Latin America, they've gone to cities and even to rural villages in terms of trying to adjust their formula to reach the lower income groups. And there may also be other characteristics, such as demographic characteristics, that help you better target your allocations. Then there's also the mechanism of contracting. We see this in Latin America and in Africa particularly, where there's a lot of contracting with non-governmental organizations, often religious organizations, both Muslim and Christian. We see this in Iran, where the Khomeini Foundation is set up to outreach for the poor. We see now some innovative programs in Latin America where the government or the purchaser actually puts out bids for organizations to come in to provide services, maybe to remote areas or to special groups in the population. There can be a competitive bid to do this, and their contracts can be renewed based on performance measures. And then there is also more and more in the way of contracting from the public purchaser to the private provider. And of course, this is something that's being discussed and considered in both Bahrain and Saudi Arabia here in the GCC. So that's the sort of for whom. Let's move to the what, to the benefit packages. I think benefit packages here, it's a pretty simple situation where you've got so much money and you want to cover so many services, and how do you do that in the best way? And there's no really best model. There are a number of models that have been put forth by the bank over the last 10 years with different criteria, with different priorities. What's interesting for me is what I find typically in the Gulf, which is there's a very comprehensive benefit package, but often it's outdated in the sense that it includes outdated procedures, technologies. There could be some nominal cost sharing, nominal copays and deductibles which are not in there. Some simple steps can be done, I think, in many countries, including the GCC countries, to start improving that benefit package. Some part of it is capacity building, training people in areas like cost effectiveness analysis and technology assessment. Other things are sort of small steps forward, such as development of negative lists, again, maybe development of some nominal co-payments. These things would start the process of improving the benefit package and probably allowing purchasers to get more for their money. This is just a list of the countries in the region where I typically work that have borrowed, not just tried to do this, but have borrowed through the World Bank Loan Program to develop new packages. But in only one case in Georgia were they successful, when they were only successful for a short period of time, when the new package was overridden by the legislature for under some political pressure from various stakeholder groups. So while it's technically sometimes relatively straightforward, it's politically very difficult to go through and to develop a new benefit package. So this is, I've gone through most of these already in terms of international lessons. Now, purchasing, we've gone through the for whom, we've gone through the what. Let's go to the from whom. Here we're talking about contracting. Let me talk about two regions in terms of the contracting experience. What we see in Eastern Europe is we see the beginning of contracting, but it's kind of an affirmation of what already exists. There's soft relational contracts. There's really no selective contracting as yet, but I think that as the management and information systems begin to become more sophisticated, there's more information about cost and quality, you will see some selective contracting. And in fact, in some countries, such as Estonia, Czech Republic, you are starting to see the development of more selective contracting, both for primary care physicians and for hospital care. In Latin America, there seems to be a bit more aggressive behavior in terms of contracting, particularly by the social insurance schemes who are doing some selective contracting with private providers. As I mentioned before, there's some effort to contract out for priority services for mothers, for young children, for people in remote areas, and we see this in a number of countries, Bolivia, Peru, and Ecuador. Now, the fourth policy tool, we've gone through the for whom, the what, the from whom. Let's talk about the how. Payment methods. I've defined payment method here. Essentially the way in which money is distributed from the purchaser to the health institution or the provider. And why are payment systems so important? Basically, you want to change behavior. You're in the kingdom now, you're very unhappy with the inflexibility, you're very unhappy with the performance, you're very unhappy with the outcomes, and you're talking about this in almost every meeting I go to. You want to change behavior. You want to change behavior of the institution and of the providers so that you improve the outcomes, you improve the quality, and you improve the efficiency. And so this is what countries are doing, this is what purchasers are doing. They're using new incentive systems to actually achieve some of these objectives in terms of changes in the mix of people, of equipment, of services, to move more services to the outpatient setting, to encourage surgical outpatient daycare surgery relative to inpatient surgery, so on and so forth. Now, this is the MOH budgeting system currently. This is the line item, the classic line item budget, which was used for many years in the former Soviet Union and Eastern Europe, is still used in many African countries, and until the 1980s was used in the United Kingdom, where there are line item budgets. You can't deviate from these line items, either between the lines or over time, and so you're pretty much stuck. And again, we're trying to move. Purchasers are trying to move from inputs. They first move to activities. They further move to outputs, and ultimately they're trying to achieve a payment for outcomes. This is just a schematic of the kinds of payment systems that you typically see in countries where there is some semblance of strategic purchasing. Mariam Wiley talked about the DRGs, basically with any payment system you have two elements. You have the price and you have the what's contained for that amount of payment. What's the unit of payment? And you have to decide on both of those things. And as you move out, as you move from the red to the blue to the yellow, things become a bit more complicated, not only in terms of defining what's in that unit of service, but also what is the relative price that should be paid for that. Here's what's happened in Eastern Europe just in the past 10 years. Eastern Europe and the CIS countries, they've gone, all of the countries have gone, all the countries started with line item budgets, both on the outpatient and inpatient side. And you can see here that over half of the countries have gone to some kind of capitation system for primary care, and over half of the countries have gone to some service, some sort of activity-based or performance-based payment for hospitals, either per diem, basically paying per day, per case, as Miriam talked about, or some kind of global budget. Similarly, in Latin America, we see initiatives both in the MOH system, and we see it in the Social Security systems, and we see very similar patterns in terms of with primary care, capitation, and often fee-for-service for priority services such as immunizations. And we see many countries moving into some kind of DRG system, and we even see some managed care and capitation pilots in some of the countries. So after you talk about payment systems, people often say, well, which one is best? Which one should we start with? Which one should we use? And the answer is it depends. It depends on several things, and before you have your meeting with the minister, you want to think about, first of all, you want to think about what your policy objectives are. Is your policy objective efficiency or equity or quality, or is it some combination? I think you need to keep in mind that there's no one perfect set of incentives, that because of information asymmetries, because policy objectives change, you're going to probably want to start somewhere, but then you're probably going to want to monitor, and you're probably going to want to change at some point those payment systems as your policy objectives change. And here I just have kind of what the literature tells you in terms of how well each of the payment models do in terms of access, quality, and cost containment. And you can see that relative to fee-for-service, episode-based DRGs and capitation do much differently on these three measures. Second issue you want to think about is implementation issues. How long is it going to take? How much money do you have to invest? And who do you want to bear the risk? Because as you move from fee-for-service to capitation, your risk shifts from the purchaser to the provider, and that's very important as to whether the provider can bear that risk. A very easy system to implement would be per diem. You just take last year's total budget and you divide it by the last year's numbers of days, and you have your per diem payment. If you want to do something that Miriam Wiley was talking about this morning, you have a much more difficult challenge. You have statistical teams, you have cost teams, you have iterations, and you have groupings that constantly need to be refined and updated. Finally, Mr. Chairman, I would like to say that don't develop and implement these incentives by themselves, but do it in conjunction with improvements in management and information systems. With provider autonomy, if you're going to put new incentives on the provider, make sure that they have the autonomy, the flexibility to react and to make those changes that you want them to. And don't forget your quality assurance systems. The classic example for me was the experiment in St. Petersburg, Russia, in the late 1980s, where they gave capitation, full fund holding to physicians, and they said it's up to you to refer patients to hospitals, but there was no quality assurance system. And sooner rather than later, people started dying at a higher rate than normal because they weren't referred either in a timely way or at all to hospitals. And they quickly ended that experiment, but with the right quality monitoring system, they would have quickly realized what was going on and could have made some midterm adjustments. So this is a very important part of any set of incentives. Thank you.
Thank you very much, Dr. Jack.